We recently decided to work across the entire agency to define what our high-level principles are around measure development so that we can be consistent across the agency. Some of our principles include things like developing measures where there is true variation in performance. In the past, a number of measures have been developed by CMS and others around processes of care for which there is actually very little variation in performance. That's something we'd like to get away from and really focus on the variation in care that really matters mostly to patients. Another major principle for us has been around the inclusion of patients in measure development, and that the patient voice in development of measures, in fact just deciding on what the right measure should be, is at least equally important to the voice of providers and payers and methodologists and to CMS, quite frankly. Another principle is around prioritizing patient-reported outcome measures, also prioritizing what I call appropriate use measures, so appropriate use of services, whether that be overuse or underuse, and of course cost, resource use, and safety measures are also high priorities for us. So another principle for us at CMS is that we remove measures that we think are no longer valuable or that have been shown not to have any impact on patient outcomes. So over the last 2 years or so, we have scrutinized our measure set to look at our measures, particularly in the hospital program as well as the physician program. But I would also say for our accountable care program most recently, to look at the measures that either are topped out, meaning there's no longer variation in performance because everybody is performing highly on those measures, or the evidence has changed, so we need to remove the measures, or we find by doing further literature reviews or by further analysis that performance on those measures, and these do tend to be mostly process measures, really have very little impact on performance on the related outcome measures.